Alright, how to dose IV vancomycin. Remember, vancomycin is the drug of choice for MRSA. It's used a lot in the hospital empirically. Empirically meaning we don't know what's causing a disease or an infection, but we think it's due to something like MRSA. So vancomycin is often the empiric choice for suspected MRSA. Let's look at an example together. If I have time later, I might do an example of adjustments with patient-specific levels. Alright, a 68-year-old male with MRSA bacteremia is started on vancomycin. He weighs 100 kilograms and he's 5'8" tall. What dose and frequency of vancomycin would you recommend? Here is vital signs. Here's his serum creatinine. First, let's calculate his creatinine clearance. We're going to use the Cockcroft-Gault equation. So 140 minus age times body weight divided by serum creatinine times 72. We're going to use the ideal body weight in this instance. We use actual body weight if it's under ideal body weight. For obese patients, we sometimes use a dose-adjusted body weight. So the ideal body weight equation for males is 50 plus 2.3 times inches over 5 feet. Here we get 68.4. So let's plug it in. 140 minus his age of 68 times ideal body weight of 68.4. Divided by his serum creatinine of 0.95 times 72, and you get 72 mils per minute. Next, we're going to calculate the elimination rate constant from population's estimates. The elimination rate constant, or KE, is basically percent eliminated per hour. This represents the fraction of drug removed from the body per unit of time. This is for first order kinetics. Remember, most drugs follow first order kinetics. First order meaning the amount of drug eliminated in a certain period of time is directly proportional to the amount of drug in the body. So the fraction or percentage of the drug removed over time remains constant. So KE equals 0.00083 times creatinine clearance plus 0.0044. We plug in our creatinine clearance and we get a KE of 0.064 hours to the negative first. Next, we calculate half-life from K. The half-life equation, again, is 0.693 divided by K. We plug in our K and we get 10.8 hours. This is our half-life. Remember, half-life is the time necessary for a drug concentration to diminish by 1/2. Typical half-life for vancomycin with normal renal function is about 6 hours. Next, we want to calculate the volume and distribution using predicted volumes estimates. First, we have to determine if our patient is obese, so we look at BMI. This is kilograms per meter squared. So 5'8" is 68 inches. Multiply that by 2.54 divided by 100 to get meters, 1.73. So 100 divided by 1.73 squared is 33.5. So technically this patient is obese. Using the calculations that we learned in school, the cutoff is 40 for whether or not you're going to use 0.7 or 0.5 in the volume and distribution calculation. Typo, but 33.5 is less than 40, so we're going to use 0.7. Volume of distribution equals 0.7 liters per kilogram times actual body weight. And you get 70 for the volume of distribution. Remember, volume of distribution is an indicator of the extent of drug distribution into body fluids and tissues. Next, we're going to calculate the vancomycin clearance. Clearance describes the removal of drug from a volume of plasma in a given time. Clearance equals volume of distribution times K. So 70 liters times 0.064, and we get 4.48 liters per hour. Next, we're going to calculate the vancomycin total daily dose based upon AUC goals. A normal AUC goal for vancomycin is between 400 to 600. AUCs greater than 600 have been associated with nephrotoxicity or kidney problems, kidney toxicity. I'll mention that dosing changed from like trough-based to AUC based. See, with this picture you can get different AUCs but the same trough. Back to our problem, total daily dose equals clearance times desired AUC. So if we plug in 400 or 600, we're going to get a range here. We're going to round to 250 milligram increments. Next, we're going to look at our dosing interval, or tau. If creatinine clearance is greater than 60, it's going to be a Q12 interval. Next, we're going to calculate our maintenance dose. So total daily dose times 0.5, we're going to get this dose range. So 1,000 to 1,250 milligrams every 12 hours. Next, we're going to do some check steps to make sure that our math is right. So first, we're going to calculate an expected peak from the dose we determined. This is a long equation. I'm going to put it all at the end too, by the way. So we have dose times 1 minus k to the negative k times time of infusion, which is 2 hours, times e to the negative k times t, or distribution time, which is also 2 hours, divided by k times vd times time of infusion, which is again 2 hours, times 1 minus e to the negative k times tau, which is 12. We're going to do this for both 1,000 and 1,250 milligrams, and we get 22 milligrams per liter, and then also 27.4 milligrams per liter. Next, we're going to calculate the expected trough. This is your calculated expected peak times e to the negative k times tau minus 2. This 2 is the time of infusion and distribution overlap. We're going to get 11.6 and 14.4 respectively. In order to get our 24-hour AUC, we need to get the AUC of infusion and elimination. AUC infusion is expected peak plus expected trough divided by 2 times time of infusion, which is 2. So we get 33.55 and 41.8 milligrams times hours per liter squared. Area under the curve elimination is the expected peak minus the expected trough divided by K. And we get 161.72 and 203.125. To get the 24-hour AUC, we take the AUC of infusion plus the AUC of elimination times 24 divided by the tau, which is 12. And see, for the 1,000 milligrams every 12 hours, we have 390.54. And for 1250 every 12 hours, we get about 489.85. So this first AUC is below goal. Remember, goal is 400 to 600. So the recommended dose is 1250 every 12 hours. This is page 1 of all the steps. Again, there are different ways to do this. And then this is page 2 for all the steps.